Hello, my name is Muhammad FAZLI bin Abdullah and my number metric is 058226 and I'm from Diploma in Radiography. So today I'm going to present about AP Chest Erect. So AP Chest Erect means anterior posterior chest projection. So we project from anterior to the posterior. So that we call AP chest projection. So the introduction of the AP chest erect means the erect anterior posterior chest view is an alternative to the PA view when the patient is too unwell to tolerate standing or leaving the bed. So AP chest projection is an alternative way of the PA chest because usually we use PA projection to examine our chest. So if we use AP when the patient is too unwell to do PA chest. So the AP view examines the lungs, bony thoracic cavity, mediastinum and great vessel. So we jump to the criticizing concept of radiograph. So when we want to criticizing the radiograph, we must use this concept, which is placement. The word in front of our concept is placement. So the P stands for positioning, the A stands for area of interest, and C stands for collimation, and E stands for exposure factor, M stands for marker, and A stands for aesthetic, and lastly N stands for name. So the first one is position, which is the position of the patient. Our projection is AP erect, so we must standing because the projection is called erect. So erect means we must standing. So the patient is standing against the cassette, which is supported vertically with the upper edge of the cassette above the lung apertures. So the median sagittal plane is adjusted at right angle to the middle of the cassette. So we just want the chest only. The shoulders are brought downward and forward. So downward and forward with the back of the hands below to the hips and elbows are forward. This is very important because it has the effect of projecting the scapula clear of the lung fields. So the image will be more clearly. And the placement A stands for area of interest. So we jump to the area of the interest. What should be seen at our radiograph? So the 3 posterior ribs should be seen above the superior aspect of the clavicle. Okay, the entire lung field should be visible from the apicus down to the lateral costopharyngeal angles, and a minimum of 8 posterior ribs are visualized above the diaphragm. Clear vascular marking of the lungs should be visible. So the example of the radiograph of AP chest erect is this one. This one is the area of the interest that should be seen in the radiograph of AP chest erect. So the next one is collimation. Collimation means we must project the central ray with correctly. So central ray angle caudate to the pendicular to long axis of sternum generally requires plus minus of 5 degrees of caudate angle to prevent clavicles from obscuring the apicus. So this one is very important to project AP chest erect. So the central ray is then angled to the level of T7, which is 8 to 10 cm below the jugular notch. 8 to 10 cm below the jugular notch. So 8 to 10 cm must be right, something right here, our T7. So that is our central ray. before we shoot our projection, we must check the central ray. Okay, so next, E stands for exposure factor. So the exposure factor is very important to get our radiograph clearly seen and to get a perfect of radiograph chest X-ray. So the next one is orientation. Orientation can be made portrait or landscape. So the IR can be put portrait or landscape. So the IR image receptor size should be 35 cm times 43 cm, or you can use 43 cm times 35 cm, which is portrait or landscape. So we use the bigger size of IR. So the exposure we use 100 to 110 kVp, and the MAS is 5 to 8 MAS. So the SID it should be 180 cm. Then we move to the M. M stands for marker. So marker is very important for the doctor to diagnose the disease based on our radiograph. So the marker is very important. So the lead marker should have in the radiograph as evidence, which is left or right. So right of left side marker is placed properly on the radiograph. So AP position of projection and marker should not obscure the anatomy. It means that if you put the marker, you should not obscure the anatomy. If we should put the marker beside the anatomy. Okay, and next is aesthetic. Aesthetic is very important. We must check the film size, film orientation is okay or not. No presence of artifact. No presence of artifact means if the patient wear a necklace, we must told them to put out the necklace because it will seen in our radiograph. So we must check the film size should be 35 cm or 43 cm or 43 cm times 35 cm. So the orientation must be correct, portrait or landscape. Yeah, and no presence of artifact. Artifact is very important. If our patient wear necklace, watch, we must tell them to put it away because it will be seen in our radiograph. And the N stands for name. So the patient ID must be presented on the film. So we must put the patient ID on the film. So we don't want to confuse which one is Ahmad film or which one is Zakwan film. So we must put the patient ID, and the patient ID must be include full name, registration number, which is RN, and exam date, hospital department. So this one is very important as our radiograph to fulfill our job. And that's all from me. Hopefully you guys understand about anterior posterior projection.